have a guinea pig and we'll go ahead and get started. And we're going to talk about visualization tonight. And, okay, come on up. Yeah. No, not for right now. We'll start at the top, since that's what PGA thought we ought to start at the top. Go ahead and just have... The director says take your shirt off, so go ahead and take your shirt off. Yeah. The thing you want to remember about visualization is when do you do visualization? When do you want to do visualization? During what part of your analysis? If the patient comes in the door, I mean, when are you going to do your visualization on him?
Right away.
Right away? That's good. Any other time besides right away? The whole time, right. From the time he comes in to the time he leaves, you want to do visualization. You want to watch him walk in, look for any problems that can be taking place in. And of course, we got ilium problems and toe in and toe out, all kinds of different things that happen that way. Even when let's say you're palpating, and we've all done this before, where you sit there for a half hour on one vertebrae going back and forth trying to figure out whether it's left side or right side. And all the time you're looking at the clock or you're looking at something else, you know, you're thinking about something else. That's the time to visualize right then. You know, you can take your finger off and visualize and move it, or leave your finger right there and visualize it. So you can watch, motion palpate with your eyes. So that can be counted as visualization too. So just keep in mind that any time you do anything, whether you're running your instrument or anything at all, you should be using your eyes and should be visualizing. Give me one of the signs. Let's say, what can we look for at visualization? Let's just say we're just going to take a look at the way he's sitting there. How about if we have you turn around? That might be better. That way you get the idea. So go ahead and sit down that way. Back to the camera. And let's say we're going to take a look at this fellow right here. What would be one of the first things you'd want to look for? Well, see if there's any curves. Not only curves standing back this way, standing this way too. Let's see what he's got. See what's going on there. You had to go ahead. Right? Dishing. Anything like that. Let's say that we have real nice clear skin, and we've got all kinds of little things going on in one dermatome. You know, does that give you a clue? Does that tell you there's a subluxation there? No, it doesn't tell you there's a subluxation there, but there's a good chance that there might be something there. How about if, this is a common one, where you see real clear skin everywhere except right across here, and it's almost like you can just take and draw a line, and there it is right there. There's a good idea that there could possibly be something, you know, right there, just slightly below. So you want to keep that in mind. Not only you're not just looking at the spine itself, but you're looking around other things too. Before we get too involved in the spine, how about extremities? That's one of the best ways to impress your patient is with visualization. When they come in and they've got a problem in the spine, and you say, "How long has that shoulder been bothering?" And they just kind of look around at you like, "Wow, how did you know that?" Or knees and things like that. You can see that one leg pointing out that way, you know. Ask them, you know, has that knee been bothering you? And that way, I think we get by the point where, you know, we kind of have a PR battle with the MDs all the time anyway. They're on TV all day saying with the aspirin saying, "See your doctor," and that. And we kind of have to impress them a little bit that we know what's going on too. So if you spot little things like that, even without touching them, you can tell them some things that are wrong with them. I think that really impresses them. So it's real important that you can do that. Okay, if you want to visualize, say, go ahead and move them a little bit and visualize. You want to go ahead that way? Go ahead this way. Now, by this time, you probably have a pretty good idea what the problem is already. If they say they have mid-back pain or low back pain, and then you can concentrate on that area. So if you want to, this patient has low back pain. How about, oh, he's already done. That's good. That's fine like that. That's fine like that. Let's say you're going to visualize, go ahead and bend him that way. And I think that's pretty clear what's going on down there. And bend him this way. And you can see as he goes to that right side, how everything stacks up right on the right side there. And as he bends, you've got a little bit more movement to the left side there. So you can visualize like that with movement. And if that doesn't help, let's say that doesn't really tell you the truth, or you're not real sure, take your skin marker and go ahead and mark him. Just draw a line right up there. You can do it on the whole spine if you want to, if you got lots of time. But just draw a line straight up there like that. And then go ahead. Does anybody have a skin marker? Director? No skin marker?
Colored chalk.
Colored chalk, huh? Sometimes you can really see the difference that way when you take and draw that line there. Also, another thing you can do and help visualize is the same way I've seen Dr. Gonstead do it on tape, is with the SI joints, where he'll take and just mark right along the SI joint, right like that, and right like that, and then go ahead and motion palpate him and do it and watch with your eyes. You don't even need to touch him, and you can watch and see how the lines move. And so don't be afraid. Like if you have to go ahead and draw on them, that's all right too. Go ahead and draw on them a little bit, help you visualize. How about the way they're sitting? If you want to take a look, we start talking about iliums. Take a look. Are they tilted one way or the other? Is the gluteals, the shape of the gluteals, the narrow gluteal is, anybody know? EX ilium. The wide gluteal is the IN ilium. Of course, with the iliums we have, there are just a number of things. Toe out is IN ilium. Toe in is EX ilium. Of course, you have to take into consideration knee problems and ankle problems along with that. But you can visualize ilium problems really easy. In fact, iliums are one of the easiest things to figure out what's going on. Let's talk about up top here. How about, take a look from the back here. You can look at shoulders for a problem in here, or anywhere a little bit lower, shoulder problem, start to tip them around there. How about head tilt, head rotation, things like that. You see their head tipped up like this, and that's their normal posture like that, you know. You've got a pretty good idea that there's something going on, and more than likely right here, more than likely on that side. And of course, you're going to check that out, but an ASRP atlas will really bring that ear up high and back like that. And, visualize that, find that. Also, you can take a look at visualize the muscle bundle here for the atlas, too. If the SCM seems to be sticking out a lot, there's a good chance there it seems to be, you'll just see it drawn back a little bit like that. In fact, you can probably see it with the camera right there. Just see it sticking out there. There's a good chance that you've got that atlas pushing on that right there. So there's a little more visualization. Any questions about the atlas at all? How about visualizing? Okay, you can straighten your head up. We don't want to cause many problems right here. How about just, let's say, head tilt from the standpoint like when they're walking in the room. You ever see people walk around like this? Or people that walk around like this? Different types of problems, occiput problems. You see kids like this, walking down like this. Okay, that's visualization. Those are things you can pick up, and when they come in the door and you see that, and you already have a good idea what to look for before they even sit down, it takes a lot of the mystery out of it. So it's real important. It'll really help your palpation and your instrumentation if you have a good idea what area to concentrate on before you even get started, if you're looking for a specific problem. So, any questions so far? Anybody got any questions? Let's visualize. Okay.
Explain how the EX ilium makes it look more narrow.
Okay. Let's have you stand up. Go ahead and tighten your pants up there. Let's take your billfold out. Okay, pull them up tight. There we go. Not a lot of difference there. Now watch. Okay, now I'm going to hang on to your hips here. And I want you to twist your shoulders this way, okay? Let me hold on to your hips. Okay. You see any change? Okay. Now what we did there, I wish we had a spine here, but what we did there was we made this side, go ahead and twist there again. What are we doing to the iliums there, as far as what we're right, and making the other side a what? IN, right. So that's, you can kind of see right there what it's going to do, and those things are really, if you just look at them, they're really easy to visualize. And if they're not easily seen, if it's almost the same on both sides, you know, don't try to make an EX or an IN. Maybe they are the same. Maybe that's not the problem after all. So sometimes people get carried away a little bit, and you know, I've seen them pulling people's pants down, trying to figure out. And I think if it's not obvious, I don't think then the problem is probably not that obvious. And you always have other things to check too, with your palpation and your film and things like that. Here's the spine. Okay. Just basically the same as when, you know, on the film, your EX ilium is going to be your narrow ilium and your IN is going to be your wide ilium. And if we just take and turn this way, see the gluteal muscle stretches out wide like this, and this way it brings it up and bunches it up and makes it pointed. So, okay. Did you have any more questions about the ilium as far as, have you been introduced as far as toe in and toe out on the ilium? I don't know if you fellows have talked about that before, or Steve went over that, or no? Yes or no? Review, okay. All right, as the ilium goes IN, you go ahead and sit down there. As the ilium moves IN, or internal, it rotates the femur head out. So it gives you a toe out on a patient. Okay, as it rotates EX, the femur head comes in, we've got a toe in. That's pretty easy. The IN is a little bit easier to visualize than the EX, and that's because the EX is easier to compensate for. If you stand up and try to turn your foot in, you'll see that from a normal position, your foot doesn't go very far in, but you can turn it out a long ways. So if you've got an EX and it's in, you can compensate by turning it out. And as you're walking, it shouldn't give you too much trouble. And that's normally what we find. We don't find many problems with the hip or with the knee on the side of the EX ilium because of that, because the EX can compensate back at the hip. With the IN ilium, on the other hand, as the leg turns out, we're not able to turn it back in quite like it should be, and it's easier to visualize that way. So you'll see it out, and because you can't turn it in, and we can't walk with our toe pointing straight that way, it causes a lot of wear and tear on the hip, on the knee, on the ankle. So on the IN side, you'll end up with a lot more problems because of that. Okay? Let's say you stand up again one more time. How about PI and AS visualization? What are we going to find with PI and AS as far as the iliums are concerned? Anybody have it? Right. PI is low gluteal. We're talking about right here, if we're looking right there. And of course, you can get right down there and measure them off too if you want, if you have any questions about that. So he doesn't appear to have a great deal of difference there from what I can see. I'm not straight behind him either, but not a great deal. It's not a good example for an ilium problem, but you got your PI, we'll raise it up or lower it down, and your AS will raise it up. Okay, you can go ahead and sit down. Let's go one step above that there. Let's say we look, how about in this area of the sacrum here? Right in this area right here. We visualize that there's a lot of edema there. It's real puffy right there. That's one way to visualize the base posterior sacrum. Usually with a base posterior sacrum, you'll almost outline the sacrum itself in a V of spongy edema, just like that. Just like if you took and drew it on there, and it's a pad of tissue, just a pad of edema that's right there. And that's very easy to visualize too. And you have the patient come in with low back pain, and you see that there's your tip-off right there. Before you even touch him, you've got a good idea what's going on down there. So that's why that visualization is important. How about visualizing, talking about a BP, how about visualizing while you're motioning that? Sometimes people have trouble determining fifth lumbar problem from a base posterior problem. And because a lot of times it's just they have a small spinous on 5, and they're, for one reason or another, you're just having trouble feeling it. Well, just watch it too. Visualize it as you're moving him. If you want to bend him forward, and he bends forward real nice, we want to bring him back and watch. See where that movement stops, and you can determine whether it's a BP. He won't be able to extend that joint with a base posterior sacrum, whereas with the fifth lumbar, they come back forever. As long as the pain doesn't restrict them, they'll come back. They'll keep right on coming back. And it's just the opposite, with the going forward. The fifth lumbar problem, you'll see no movement there at all. So you can watch that movement along with feeling it. And it's just keep your finger right there and just watch it move as it goes. So let's go up a little higher. Talk about rotation in the lumbars. Rotation in the lumbars is, I think, one of the trickiest things to visualize. And so I think the film, sometimes I think, oh boy, that guy's got rotation this way a lot. And you look at the film and it's just the opposite. So I don't know if that's one of the most, it's probably not the best way to really determine the rotation there. You can usually see a scoliosis there and pick it out and know what's going to be on the film. But as far as the rotation, I think because the mammillary processes are small, transverses are practically nothing on most of the lumbars, and they're quite a ways in. Excuse me. And mammillary processes aren't that big, and so when they rotate, they don't push a lot of tissue out with them and give you real high bundle on one side and real low on the other. But move up a little higher, and it can be a major factor for telling you what the problem is there, or giving you an idea what's going on. We come up along here and we see real high on one side and, of course, real low on the other, and we know rotations. Let's say we're high on this side right here, like he is. What's the rotation on this one, in this area right here? Everybody's pointing, but you got to say it. So I turn the camera and show them all pointing. Rotation's right to the left side. It's brought the transverse out. So that's another thing you can visualize. Also, while you're visualizing that, not only looking for the rotation this way, look for the break to where it starts to rotate. And if you get up and look down like this, get up and look right on down the spine like that, you can see that it's right there. It's right about there. As he comes up right here, everything's fine, and then, boom, that one's rotated quite a bit posterior on this side right here. And that's real tough to see from the angle you're at there, but just remember to get up on them like this and look down the spine this way as you're visualizing. And there's a real good chance that he's got a good one on that one there. In fact, it even coincides with some of the other things that we visualize there. How about some of the things that we call birthmarks on the skin? That's another thing that Pete was just pointing out last week there. He was showing me that we had a patient that was in and had a patch of skin here that was brown. It was like a birthmark type pigment there, and it just happened to be in the dermatome where the problem was. And he said that a lot of times you'll find that, and you'll see that there and not know what it is. He said what that is the nerve damage. That's permanent nerve damage will cause the decoloration of the skin there. So you'll see different things like that. And there are such things as real birthmarks there too, but a lot of times you'll see those things and they'll show up in the same area as the problem. Show up on the same side, problems on the left side and the exact same dermatome. It doesn't have them anywhere else. There's a good chance that that's what that is nerve damage. So you're not only visualizing that's where the problem is, you can also visualize. Your visualization will tell you that the problem, let's say Mr. Jones bent over and picked up his comb this morning and he hurt his low back. You'll hear that story time and time again. I picked up a cup of coffee and I hurt my low back. Well, you know as well as we do, we all know that the cup of coffee didn't hurt his low back. It's just a problem that he had there for a long time that finally got bad enough that that was just enough to do it. And so what we want to do, we want to make sure that because he just had pain one day, that he doesn't think that we're going to fix it in one day and then he's going to be good for the rest of his life. We want to make sure that we let him know that problem's been there for a long time. And visualizing that spot there will help you, not only you to understand that, but for him too. You can say, have you ever noticed this spot right here? And what that is, that's from nerve damage. It'll cause discoloration of the tissue, and explain to him. That problem has been there as long as that spot's been there. Say, well, I've had that spot since I was 6 years old or 8 years old. And you can let them know right then and there. So that can help you out with your patient management quite a bit. Okay. Any questions about anything like that? And that goes just not for that type of what we call birthmark, but there are other types too. Sometimes you'll see a birthmark and it just happens to be right where the problem is. And you can let them know that this is there because of that. So, okay. Any questions about that so far? No questions so far, huh? Okay. Let's go ahead and continue to visualize something on him here. Let's bend him this way. Okay. Bend him this way. Let's do that again. Real slow. Okay, that's fine. Okay, that's fine. So as we're moving there, you can see that there's quite a break right here where this starts to straighten out. And even when he's just sitting here, the spine comes a little bit this way, so we've got a little something going on right in this area right here. Now, as far as visualization, as we're, say, checking him out, and we're going to be putting our hands on him a little more now, we start to check for edema and different things, and we go up and down the spine with our fingers, and we use the instrument, we go up and down the spine. A lot of times what you'll see, the red tracks that you're going to make, or the red marks that you're going to make, come down to a certain point and then stop right there. They'll stop right there. That's something, you probably don't think of it. You see it all the time, but you don't think of it. That's something else to tune into, that's a good indication that there's, right there in the area, there's a change from up here as opposed to down here, and there's a good indication that there's a problem right there. So you got to keep your eyes open. You keep your eyes open the whole time. It's hard to keep your mind open though, and to keep thinking about things you should find. So, okay, let's see here. We worked our way up to this area right here. Visualization in this area right here. What do you see all the time in this area? You can visualize. What do you see here? That saucering is a little lower than this. We'll talk about saucering there. Right, there you go. Great big puddle of edema. You see it on women constantly. You see it quite often on men too. He doesn't have anything there at all. But you see that big pad right there. And you can tell by looking at that they've got some kind of a problem in that area. So there you visualized another problem. And again, use that visualization. You let them see it too. Say, look in the mirror right there. Get so you can look at the mirror at your back there, and you can see that area. You let them see that, and that'll let them know that the problem just didn't come, last week like they said it did. How long have you had this right here? Get out some old pictures and find those. See those old pictures. I had a fellow come in about 2 weeks ago. His head was, let me put your head, let's bend your way forward. Okay, now bring your head up just like this. His head is just like this, okay? And naturally the problem had just happened the night before when he was drinking, he said. And it was a problem that I thought had been there for years. And let's see, he had a little bit of this too. He's about like that. And I told him, I said, Mike, this problem just didn't happen then. He said, well, why can't, he wanted to know why you couldn't fix it one time or 2 times. Well, it's going to take us a few times because the problem's been there for a long time. You just haven't noticed it. I said, look in the mirror and take a look at the position your head's in. He said, yeah. He says, I just noticed that this morning because I was hurt and I was looking. And I said, well, if you go back to old pictures of yourself, you'll see that the same thing. You'll be able to visualize that same thing. So the visualization for you, let them know too. And that'll help you give you a little control of them. Let them know what's going on. So they'll go back to their old pictures and they'll say, hey, my head's been like that for a long time. So they'll know that the problem's been there for a long time. Okay. Any questions so far? Anything? Anybody got any questions on it? Anybody want to come up and find one or look for one? No? Look for a problem, right, right. We don't have an instrument, we don't have, let's say you can't use your hands for palpating the spine, but let's find something that,
Why don't we change the body?
change, okay, sure, that's fine, that's fine, that's fine.
I looked at him, I think it's fond of him.
Who's the guinea pig?
No, we can take
No, I don't know.
Okay, we got a guinea pig. Who wants to help visualize, and we'll all watch.
Sure.
There we go. We got a subject. We got a doctor and we got a patient. Okay, go. You're gonna watch him stand. That's right. Good. You're gonna look at him standing first,
back up so that it can't look too
or just get down a little bit or something there. Okay. What's
To me, right now, you might have a PI right here.
okay? That looks a little bit lower. Okay. How about anywhere else? Anything that looks real obvious on him? Pick out those things first. What looks obvious on him? Did I just unplug a light or something? Does that thing have a cool-off switch on it or something? What looks real obvious on him? How about, right, okay, the lower shoulder. How about this? How about that mark right there? I mean, he might have just sat back and scratched himself, but you never know. No, right here, right there. He might have just scratched himself, but then again, you look at those things because it definitely stands out. How about this right here? Well, remember what we were talking about before?
Yeah.
See that right there? It's a good chance that there's a little something there. How about this right here? It looks like a scar, but it might not be. Who knows? Scar doesn't grow a hair like that. Not bad. Not bad. There's probably better examples of that in the room. But you see that right there. Okay. How about another thing? How about this? How about you see somebody that's got a little scar there, a surgical scar, and you think, well, now you just had a little surgery. They've been cutting on him. Well, what happened, Miss Smith? Well, I just had a cyst removed. I had a cyst removed right there. Just happens to be in the same dermatome on the same side of the problem that you found. So that again, it'll reinforce your findings that there was a problem in that area. Would a problem in this area cause a cyst? Could. Will it cause cancer? Could. It could cause anything. So when you find anything in that area, even if it's a scar from a scratch that's been there a long time, why didn't the scar heal up so you couldn't see it anymore? Could there be something keeping the scar from healing right? So just anything, you got it. Anything you see at all, anything at all. You go ahead. That's a mole, but you always want to note those two.
Yeah, it's fine.
How about the
Coloration. Right over here.
Good. Very good. Very good. How about just taking a look, seeing what seeing what we've got as far as the head tip. How about the muscles right here? These are very easy to visualize on most people right here, and take a look and see if there's rotation one way or the other. A lot of times you're down in this area trying to figure out what the rotation is. What is the rotation of this area? And you look up here. Here, let me turn your head a little bit. Okay, let's just say his head was straight ahead, but you see this in the neck here. You're trying to figure out the rotation here. Take a look right up here, and it'll tell you. There's very little chance that this is rotated right, and those are rotated that far left. Those are that far left. There's almost 100% chance those are going to be right. Again, your film's going to tell you for sure, but that's just just don't get your eyes right there. Go ahead and look around, look at the whole area over. So.
Is that what's happening now?
With this, I just turned his head. I had him turn his head. There. We just fixed him. It's a miracle. Okay, is there anything else you want to look at while he's standing up?
The right scapular looks a little bit smaller. Larger.
Okay, more prominent, sticks out a little bit more. It looks higher. That could be a problem too. That can be a problem in that area. So really not a lot of scoliosis as far as, you know, any curve, lateral curve there. Really doesn't have a great deal of problem there. How about from this angle here? What do you see?
Turn sideways.
Yeah, once you turn sideways to the camera that way. Doctor's got to go over that way too. How about checking him that way? Looks pretty good? Okay. Okay. To me, it looks like both shoulder blades here are a little prominent. Now, either he's holding the shoulder blades back, which I doubt, or this is just a little dish here, yeah, just a little dish right in here. Okay, so they look just a little prominent right there. A little hump there, and he looks very flat right here. Take a look from the side there. I bet his film, I bet he looks like he's in the Army there in his film. Okay. Anything else you want to do standing up? How about the feet? Did you look at his feet and see if... Oh, now he's looking and he's rearranging them. Okay. Move the chair. Okay. What you can do, face straight ahead, look right at the camera and march in place for a couple steps. Look right at the camera. Okay, that's good. That's good. You can stop. Okay, there you can take a look. Yeah, there might not be enough to really tell. It's hard to say. I'd say if you looked at these back here, I'd say this side is IN, this side's EX, by that back there, and I think that'd tell you the same thing right there. Do you see?
Yeah, this one.
This one's a little bit flatter and wider. This one's a little bunched. In fact, you can put your hand on him right here, and I don't like to do this, but you can put your hand on him right here, and you feel that this side right here is flat, and feel this and it's round. See the difference there?
Yeah, you can just look at that and see that.
Yeah, okay, that's the part. It's not so much how wide it is, but you'll see that EX is all bunched up. Yeah, EX will bunch up, and that's exactly what his feet are telling you there too. This one's out a little bit more than that one is. And that's something too you want to take a look at from the front. Never hurts to take a look from the front when you're deciding the ilium problem, and look and see where his zipper lines up, because that'll make a difference too. Yes, yes. And there's just all kinds of different things that'll twist and turn. Of course, you've got other problems that'll cause that too, but that's just, you know, that isn't proof positive of anything, but it just gives you an idea that if later you find an IN ilium on him, that everything all fits together, you know, all these other things too. You can think back and say, geez, all this other stuff works the same, you know, all fit together, so. Okay? All right. Let's, anything else, Shannon? You want to have him sit down now? Let's get a chair. Oh, you don't want him to touch that. Okay. Let's have him sit down there. See a little cheek, huh? Okay. Not only when you're... Okay, you can see them when they're... Oh, that's enough. We're not going to get into cheek films tonight, are we? We don't want to rate this movie X. As you've got him sitting, okay, we've already visualized the different things on the skin. We've already visualized the curve. Now you can go ahead and put a little motion to him. Or how about when you compare when you're sitting to when you're standing? What should happen to this curve when you go from a standing to a sitting position? It should just go the other way. It should flatten out. What if it doesn't? What if it doesn't? What kind of problems are we thinking about? Pain. Always think of pain for changing anything. But how about a base posterior sacrum, keeping that from going the right way, going the way it should, or rotated sacrum, or ilium type problem. So that's just something else you can visualize. Also, see if this changes. See if there's any changes up here. Now you can get up and look down on him and see where there's a break, and see if you come to a certain spot. Is it right? You can see it's pretty obvious on him there. Okay, now what do you want to do? Visualize the high side. Which side's high on that?
Like the left side.
That's an obvious one too, isn't it? So we've got a good idea that we've got a problem right in this area, and we've got spinous to the right side there. And in fact, I'd say it's about right in there, right across there by this right here. Okay, now we can go ahead and move him. Go ahead and move him and watch. And this is where I really like to, have a few marks on him. I always scope him before I start doing the axle movement. And after you have a few marks on them, even if they're marked this way, rather than, straight up and down, even if they're marked this way, you can see a lot of things that way. You can see if those marks bend over like they should or whether they don't. So let's bring in this way real slow. And sometimes the very first part of the movement tells you more than bringing them clear over. Okay, what do you see there?
He's got more movement to the right than to the left.
Okay, I tell you where I'm. Okay, you guys are looking up here. I'm looking down here, right across from this right here, and see what you got there, as opposed to going this way.
Yeah.
You can feel the difference there. Yeah, that's pretty. That one's a pretty obvious one. Let's see what we had. That might be too far away to get a dermatome on that. He's pretty flat right in there still, even sitting down. Sometimes they sit down and it'll make a big change in that curve here too, that compensation. When that compensation stays there when you're sitting down, as opposed to, stays there sitting down and standing up, there's a real good chance the problem's been there for a long time and everything is just rigid in there, really, really tight, locked up tight. Sometimes you'll only see the compensation when, one position or the other. How about the neck here? Does it seem to be about the same as it was standing up? You want to take a look from the side there. That's right. I thought it added just a little bit there. So there's a good chance that, there's some hope for this fellow. Through chiropractic, and hope he's got good insurance. Right, and it appears that this softened a little bit right there. That's pretty flat right there. So just from visualizing on this fellow, I'd get a good idea right this area. There's something right here, something right there, and from that right there. So without putting an instrument on him, you've got kind of a good idea what might be going on there. We didn't check out the top a whole lot on him. Let's take a look here. Again, we're trying to do this without using anything else but visualization. Can't. Got to look from the back. Yes, he tilts to the left, but I was looking. Okay, look at the muscles there and see if you can see a difference from one side to the other there. You almost got to look from straight back, I think, to really get a good look at it.
Right.
Maybe he moved a little bit. That's it. It's not a great deal. Okay, it's not a great deal. I thought I saw a little bit more on the left, but it might not.
Flatter, wider, like maybe it might move.
Well, anyway, and again, don't struggle over little tiny things. If you can't see a difference, there might not be a difference. So, I've seen guys stare at a film for 20 minutes at one vertebrae trying to figure out whether it's rotated right or left. And just say, what is it? Well, it might be dead center. Who knows, So don't fight over it, just go with it, whatever it is. Don't let it bother you too much there. Okay, any questions about that? I think he was a good subject to visualize there, as far as a couple of problems on him there.
How'd you get these two, the upper thoracic?
The upper thoracic one, mainly because this is straightened out. When you see that straightened out, you always go below. When this straightens out, you go below. Most compensations take place below. Few exceptions, of course, when you have an upper cervical, a lot of compensation. What's that now?
Because it's curved straight.
Oh, because it come back a little bit? No, I think that just tells you a little bit about maybe the length of time it's been there. If you've got somebody that you look at from the side and they're just straight as an arrow, and you sit them down and they're still straight as an arrow, that thing is just locked tight. When you sit down, that little bit of curve should come back in that as opposed to standing up straight right there. Now, just the opposite down here. You take the curve out down there. But if the curve stays in there, then you've got something going on down there. See? good chance of an ilium, probably good EX ilium. What's an EX ilium going to do to the lumbar spine?
Hyperlordosis.
Hyperlordosis, right. How about the PI ilium? Same thing. Same thing, and the IN is the IN and the AS are the opposite. What's going to do it worse? What's going to do it worse? What's going to make a worse hyperlordosis, a PI or an EX? Or an EX?
Oh.
What's of the two? If you had 2 millimeters of PI or 2 millimeters of EX to choose from, which one would cause the worst hyperlordosis?
Yeah.
The EX would, right. In the same way with the leg change and the leg length. You know, we haven't got to even laying them down, but leg change and leg length, the IN and the EX are always a little bit more of an offender. Everything they do, those two will do just a little bit more, usually with the curve and with the leg length. Dr. Gonstead, you know, put 2 millimeters to 5 millimeters on each of them, but and I've heard Phyllis Markham say that just a little bit worse with the EX than with the PI and the IN and the AS. So, but anyway, that's off into other things. Any more questions about him visualizing?
When you got saucering, what's causing the saucering? Is it because the spinal fibers are closing down like that?
Well, sometimes you look at the film and you see a lot of bent sinuses and really just nothing there. And I've seen that before, but more often than not, you see, if you look at the lateral film and you see that the vertebrae are stacked in there or straight in there, there's a good chance that there's a problem below it. Anytime we see, if we saw 5 vertebrae that they were in trouble, let's say we use the instrument on this fellow and we got a reading here, 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 and here, all those right in there. Where would you go to? If you had no other idea which one to take, which one would you take? Take the lowest one, right? That's right. That's right. Start with the foundation. That's the main idea. We start with the lowest one. Okay, go ahead.
If you palpate the lowest one, and you have maybe 2 of them that are sore at that point on touch, then you would take the lowest of those 2.
Well, I think not just from touch, but like from all of our findings. Let's say we get an instrument reading, you get fixation, and you're really in your mind, you think, God, I think there's 3 of them in there that are subluxated. Good chance it's not 3 of them, but there's probably just 1. And Dr. Gonstead would always say, start with the bottom. If you've got 2 that you're undecided about, start with the bottom one, and that will always be your best bet. You will know I think when you do the wrong thing, you know the next time. They'll come in and they'll say, hey, I got worse, and you say, oh, we expect that, you know. No, you don't tell them that. You tell them, take the blame for it. Take the blame. Yeah, here. Any other questions about this? We can do a little more visualization with them laying down. I do most of mine, you know, just sitting, but sometimes when once in a while when I actually do an orthopedic test and have somebody laying down, there's some different visualizations that you can do laying down, too, that might help. So why don't we go ahead and do that? So why don't we have you hop up there, face down, and... Is it working? Okay. Okay. Whose idea was it? Yes. Hello, fellows. Let's see here. Now I'm just trying to remember what I was talking about before. Okay, with the SASIN ilium, the reason it makes that leg turn short is because it tips the ilium in a PI direction. It doesn't make the ilium PI, it tips in a PI direction. That shortens the leg. And to do that, what it'll do is, the only difference between that and the problem not being there is because the sacrum stays tipped in this direction, okay? And if you find it down there, take a look up here and see what you see. See if you can see a difference when they're laying down, if it's tipped this way. See, if you tip him this way, it's going to make that right leg shorter. If you tip him this way, it's going to make the left leg shorter. So if you suspect the SASIN, go up here and visualize it too. Go up here and take a look and just see if he's this way or that way. So, and you can see a little bit of that. That's one of the tougher things to visualize. There's usually the check is down here that we use to find that. So it's just the leg length. We don't flex the legs up. We just look at them as they are. Okay. And that's always best done on a high-low. Have them stand and then go down, rather than have them crawl on a table, because that changes some things around. And
doing a leg check with the patient supine?
I've never heard of it done supine for that type of problem as far as Gonstead. Yeah, they do some leg checks supine. All I know is that when you in the prone position, the legs should be the same as they are in the standing position. In other words, if the right leg is 5 millimeters long standing, it should be 5 millimeters long laying down. Or, you know, we're talking about millimeters, but, you know, that's the idea. It should be longer at about that much. So as far as turning them over supine, I really don't know what kind of change that'd make. Whether that would change all that information around. I'm not real sure. Because I don't know if a lot of Gonstead people use supine. You know anybody that uses supine as far as a Gonstead practitioner?
A lot of people would say they're Gonstead.
Oh, okay. Well, all right. Maybe they have some other information we don't. But anyway. Okay, so that's pretty much, you know, just the same basic things that we were doing standing. You can do laying down and check on him there. Any questions about anything here as far as visualization? Nope. Okay.
Pressing on the sacrum will cause give you differential and
Changing that. Yeah, I'd never used that in practice. I always had to do that in school to see if that made a difference there. I've never done it since school. I know I've seen. Supposed to just find a fixation in the SI joint, then, right? Doing that. How about? Do you have any questions? Any questions at all on the spine? We can do visualization of some extremities too. Would you like to do that? Okay. How about go ahead and sit up there? They're tired of the spine. They want to see something else there. We're going to check your extremities out. Okay. Visualizing a shoulder problem is one of the easiest problems to visualize. And when you spot those, without them telling you that, again, there's your...
we get you back on the chair.
Oh, okay. All right. Call in the movers again to the front. Take a look, and you'll see where the clavicle comes over, where it attaches to the scapula, and you always see all the different bumps and everything that are sticking out over here. Always take a look and see. You see one sticking up. A lot of times the patient will come in and they'll say, "Hey, I got this bump over here that sticks up higher than the other one." But what it isn't actually that bump that's sticking up higher. It's that the shoulder in the socket has slipped down, and it gives it an appearance of a real bony shoulder, like what I would call this one right here. As far as visualizing, I'd say this is the side that's got the problem. Now that's just some visualization. Again, you want to check it and that. But can you see that? Is it possible for you to just taking a look from the back? I'd say Jim got some problems with the right shoulder in the past. And then, sometimes you'd be wrong. They'll say, "No, it's my left one that hurts. My right one hurt before." So you get shot down. And most of the time, what'll give this type of problem is when the arm is pulled, lifting something heavy, anything that would pull the arm this way, that type of AI movement, that'll give you that look right there. And it's as simple as that to visualize it. Now he's got the, looking from right now, you can see that cervical visualization there. I don't know if you can see that on the camera.
Did you mention that can be caused by the simple twisting on the axis?
Right. It can be axis too. I always think of it more for the atlas because I was talking about the rotation as it goes too. But the axis can cause it. A fifth cervical can cause rotation and tip. But again, you're getting to that area. When you see their head tilted like this and like this, and they've got low back pain, you also know that, well, there's something going on up there. Let's investigate. You're going to check the whole thing out anyway. But there's a good idea that something's been going on in there for a long time. So, but yes, it can be anything. Also, you can always visualize the joint here, the clavicle,
Yeah.
and a lot of times that'll stick out, and that pops up this way. It's like it's a bump underneath there. What do you see there?
Left one.
Yeah, you guys are from the front there, but go ahead and check those out. And whenever you've got a shoulder problem, I'll say it, whenever you have a shoulder problem, always check the clavicle, because the patient says, oh, I can't bring my arm up any higher than this, and you're fixing that shoulder and they're getting a little better. I bring up a little higher, they get to a certain point, no more pain here, but they just can't move anymore. Check that out. Don't ever let that go. Whatever it takes to injure this can certainly injure that too. There's nothing that says you can't hurt them both at the same time. In fact, you probably do a lot of times. So always check that out too. Check it out here. I can't say I've ever seen one that's been subluxated with this end. I've only seen them back here. I've only seen them back here. And when they set with a snap. It's just a high, it sounds like you broke something. It just snap. Because it's just that kind of joint for some reason. Pow. It's not like a vertebrae at all. And they'll stay good. You can always have them take that. And that'll stay good. We're getting off visualization here. Shoulders, okay. Well, you can spot the low shoulder. There's his AI shoulder right there. Elbows, as far as visualization, you can visualize them on women a lot easier. They don't have as much muscle around it, and a lot of times you'll see that thing in like this. You see that thing in like this. I can't even do it on him. He's in pretty good shape, but you'll see it bowed in like this a lot. And the problem with that, the problem that goes along with that, you can always visualize just the wrist too. Have him bring it down like this. That you're going to have to get a little movement for, and you'll see that thing pop up. You'll see it turn, the skin turn real white and blanch right there, and you'll see that. Check that out. See, I've got a real good one, so I've got a real good one to see there, just like that. Now compare it to the other side. See, I got nothing on one side and a big lump right there, so you can just visualize and see that there's a problem there with that one. The simple joints of fingers, really nothing to those. You can see if they're crooked. But now, getting to the knees, I think one of the best ways to visualize the knees is where we were before, when we were prone. Also supine, you can visualize the knee there. You can also visualize the knee standing is a good way. When you find that toe pointed out, there's good chances of problem with that knee that could be causing it too. You can go ahead and see what's going on there. Now, there's many different knee-type problems, and so getting into visualizing all that is, there's so many different ways that, so many different listings on the knee. But there are a couple things that you can look for. You can look for when they're standing, whether they're bowed in a little bit, bowed out a little bit, as well as toe in, toe out. Also, visualize the kneecap. Go ahead and take a look at that kneecap when they're standing. Like it works good with girls because they have the gown on. Take a look at the kneecaps and see if they're in the right spot when you're X-raying them. You can see it. You can see it when you're X-raying them. It's the best time because you're having them stand there, and you've got to check from position anyway. So take a look at the patella and see if the patella's in the right place. Is it hung one up completely higher than the other, or lower? You take a look like that. The one that's higher will be the one that's in trouble. And when they sit down, does that patella come down a little bit? Does it move? And that's something that's very easy to visualize. And you'll find out you fix the knee and you fix the knee and you fix the knee and they keep hurting it again. So you got to fix the patella too. That protects that knee. So you have to get that fixed. I can never understand that. The patella seems to me like it protects the femur more, but I think you find more patella problems when you find the tibia problems. Like posterior tibia, it seems like the patella seems to go along with that a little more often. It seems like it's more important to fix the patella on that one there. But, and again, that's something you can visualize. Just keep your eye open for things like that. The ankle problems you can visualize. You can see them sit like this, and you look down and the ankle's twisted in like that. And you can tell that they've had different type of ankle problems before. Of course, with feet, flat feet, bunions, you can visualize. How about claw toes? You can visualize that problem easy. A lot of things with the feet that you can visualize. Those arches, when those arches are dropped, there's no way you're going to, well, there's a good chance you can really help out the low back if you take care of that too.
Can the upper lumbar drop an arch or the lower lumbar? In the military,
It depends. Now, if you've got dropped arches on both sides, I wouldn't. I would go. You'd have to go a long ways to say that. I think the lumbar would cause both sides. If you have dropped arch on one side, I would say you could have a lumbar problem that would cause that. A little more probable. What's that?
Is that nerve?
Why when he's got a shoulder problem here, why are we going to find his upper thoracic problem on the right side up here? You know, why when the knee problem's on the right, why is something in the third lumbar area going to be on the right? If it's on the left, then it probably doesn't have any effect on that knee. But if it's 95% of the time, you'll find it on the right side. And why did the knee go bad in the first place? Well, I bumped it real hard. You ever bump your other knee real hard? Yeah. Why didn't it go bad? Well, maybe that had proper nerve function to it. Maybe just the one that couldn't take the strain quite as bad. Or when it got hurt, it didn't heal itself, or it didn't heal right.
The most foot problems are, I guess I can't say that. I was going to say that most foot problems would be more nerve than mechanical. But a talus can cause that tibia to rotate, causing that femur to rotate, causing a change in the pelvis. So I guess that's
right. You can go both. You have to take care of the whole patient, but I wouldn't. I don't know if you can really make a rule out of it. I think the only rule you can make, and the one that you can follow real close, is that if you're fixing an extremity without fixing the spine, there's a good chance that you're not going to get it all, that you're not going to keep it better. You can fix that. You can fix this shoulder, and that shoulder stay good for a while. Is it going to get in trouble again? I bet you it is if you don't fix this right here. Because to my thinking, and it should be all yours too, your chiropractic college, that this is what starts it all. Whether it's cancer or whether it's anything, that this has something to do with it. There's very few instances, I think, that something didn't come from back here. So if you're taking care of an extremity, I got to take care of the spine too. And what I always do, they come in and they've got an extremity problem. I take care of like if they come in, they've got a knee problem and they have a third lumbar on the same side, I take care of the third lumbar first until they tell me the knee's better. Then I start on the knee. And you'll find it almost, I had a lady back at college, and she had a knee. It was just like this. She walked just like this. She couldn't straighten it out. I had to x-ray her like this to get them both even. To see, you know, you're supposed to get them even. Couldn't lock, that was it. And I thought, oh my God, the x-ray nest just torn up. They're going to put the artificial joint in it. And I thought, wow, you know, I'm going to need some help on this thing. And I adjusted her. She had an EX ilium. You know, I was thinking an IM, but she had an EX ilium. I thought, go with it. Just do what you find. And after about the second time, she's just come running in and kicking her leg, and it's the first time she hadn't had pain in her leg for years. So when you think, no matter how bad the knee problem is, always think about the spine too, or any extremity. No matter how bad the problem is, no matter if they crushed it in the car door, still, you know, they obviously had an accident to it. Still think of the spine because I think it'll get better a lot faster if you can fix this too, and it'll stay good as long as you keep this fixed. So that, talking about ankles and flat feet, I think that kind of goes with that too. You know, you see a lot of things in the magazines about foot levelers and different things, and those are all good. But you know, a lot of people are making a practice out of putting things in people's shoes and that, and you know, maybe they feel better, but is that taking care of the spine? I don't know. I think they get a little better results if they take care of the spine too. Spine levelers. I don't know. Well, we're over here. Bunions, you can, okay, feet, back feet. You can always see bunions. Real easy. And they're a very easy thing to fix.
Why don't we get someone to take the shoes out so we can look at the foot?
You got an ankle?
You got a bunion?
You got a bunion? Who's got a bunion? Even if somebody can't get anybody set it all the time. It's just, you want to get that fluid back in the joint.
Mm-hmm.
And you can do that just by taking hold of it yourself and just putting the pressure on it there. Go ahead and just hold that like that. You can hold that like that and then let it up and then hold it again, let it up. And you'll notice the difference when you're done, that the fluid will have a tendency to stay in the joint there. And that'll help it out a lot, because when that fluid stays outside like that, it tends to harden over a period of time, and it kind of accumulates down there. Yeah, I couldn't see the difference that I really wanted to see, like I've seen before.
Okay.
Can you see what you? Can do the other one.
What were we looking for?
What I was looking for was, put that one down. Let me show you what the good one here is. The inversion. In other words, the ankle will be like that, the bad ankle, the old one. And I think his is just a little too much swollen still, and it's holding it straight, which is the protective mechanism of swelling there.
I think mine was again. I had my belly broken off.
Oh, you mentioned broken off. See, now now we're talking about a bony change there that'll change things. But I'm more or less just an old chronic ankle. When they pick them up, will hang in, and you'll see it. Now one won't, one will, and you know that's the one. There's your visualization telling you what's going on there. So, and that's a good. And anytime you have an extremity problem, is a good clue that might be the side that the problem's on in the spine. If you've got say a third lumbar problem, or let's say any lumbar problem, and you motion palpate the heck out of him, he can't decide. You look at the film, you can't decide. You got a bad hip, a bad knee, a bad ankle. There's a pretty good chance it's on the right side rather than on the left. Or maybe it's pretty much dead center. It might be medial type disc, but that's a good indication. Let's visualize him the rest of the way here.
So what do you think the talus needs to be set on?
Yeah, that looks like right there. Do you twist it in like that?
Yeah, well, there's like a step on tennis balls, like this.
Like that way. Yeah. The swelling on the inside, it should get a little bit of swelling there. I think you just get a few broken blood vessels there, and just the edema there that comes down. If that comes hard enough to hit right down in there, you'll get it all swollen up. But I think most of the damage takes place right there on that one. And then set that across there. Have you had it X-ray?
Yeah, I had it X-rayed.
Everything was okay?
Yeah.
Okay. Now that's what you got to do is just get somebody with the X-ray and get them to go ahead and set that. There's guys around here that know extremities, don't they? I mean, they teach you extremities. I know Pete goes up here and teaches extremities.
He doesn't teach you anymore, does he?
Mm-hmm.
Does he?
Mm.
Not this quarter, does he?
No, not this quarter, but there's Keith would set it for you. If you're somebody that set ankles before. But that'll help that a lot, and you can help it a lot by keeping the swelling back in there.
Mm-hmm.
Keep that fluid back in there. But even though that's a good example of a twisted one, it's not a good example of a chronic one that we wanted to visualize there. Visualization. How about of the jaw? How about of the nose? You set the cartilage on the nose.
Let's check his out.
You can see a crooked nose. Okay, and that's and that can be set. In fact, at the GAT seminar in Minneapolis, Steve Rindle had this guy, and he had a honker on him, and it came down and it was this way and this way. He was explaining how it can not only go one way, it can also go the other. And he set it one way, set the top part first, and the guy's nose was going clear over to the side then. And he says, now I'll get the second part. And he got the second part and then straightened out. And he said, it'll stay straight for a certain amount of time, and then he set again, for a little while. And it was weird because it was right on camera, dead center, and this guy's nose went over and back, You set that part, and it was just like that. And then you set that part and straighten it out. And you could just see it. You wouldn't think it's something you can really obviously see. So you can visualize the nose. How about a jaw? You can visualize that. You can feel that, you know. People can feel back here. The way to visualize it, you can look from the front. I like to get the chair back. Scoot forward a little bit, and I'm going to show you how I do it. I lean the chair back just a little bit farther than normal, and that way you can tip your head back. Lean right on me. Bare your teeth. That's right. And go ahead and open your mouth real slow.
Okay, we got a problem here.
Okay, yeah. See, his isn't real obvious. See, his comes a little bit his comes down a little bit to the right, but not much. It might be within normal. Yeah, you'd be able to see his on camera. Back to camera up about a mile. Okay, I'll leave you forward here so the camera can see, okay? Go ahead and drop the jaw real slow. Okay, back up again. Okay, now this time, look at that. Before you do it, bare your teeth. Just bare your teeth there. That way, you really don't need to that much with him. Do that again. So that is how you visualize the jaw. That's pretty easy. But if they're not quite that obvious, have them bare their teeth, and I like to look down, have them tip their head back, and so you can look straight down, and you can look for the space in between the top and the bottom, and watch it. It should go down and come back up smooth, and you'll see it go down and zigzag and do all kinds of neat little things. So that's just visualizing the jaw. Sometimes you can just visualize it too, and it's just part way open. It'll just hang to one side or that type of thing. So, see anything else on this guy we want to visualize here? Yeah. Any questions about any of the extremities there? So you can. I don't know if I left anything out there.
Talk a little bit about ribs, too.
Ribs, okay. I've never adjusted a rib up here. Never adjusted. I know some people adjust a lot of ribs. I've never had one that stayed bad after you fix the problem in the spine. Usually they'll come back like they ought to be. Sometimes after you fix this 4 or 5 times, they'll turn a certain way and kapow! That lump that was there isn't there anymore. That thing will just set back in there. So don't set a lot of ribs a lot of times, but you'll see them stick up just as a lump right next to the sternum there. And I think they're you'll get more of it in the back, is where you'll actually see the rib slip a little bit. And again, I've only set a couple of those, and more times than not, they're right there on the same segment that you're going to adjust anyway. And very rare to see rib. I know we didn't talk about that we probably should talk about is scapula.
Yeah.
Scapula. There's really no joint. Really not a joint that we're gonna talk about. There's really no joint for the scapula, but sometimes it'll get hung up a little bit superior, and it's kind of like a fibrous adhesion that takes place between the scapula there, and it can be very painful. It can be very painful, and I always think of that when you've got a sharp pain in this area, because most of the time your pain in this thoracic area is going to be a dull ache or a burning sensation, that type of pain. Anytime you have a sharp pain, you think one intercostal neuritis, which you've got a problem in that area, or a possible infection, or maybe a scapula. So it's more often than not it's a sharp type pain, and it's breathing makes it worse. Lifting the arms, of course, makes it worse. To visualize it, you can just stand behind and look.
Does anybody have any problems?
Mine, I have a real bad.
You have a real bad one? Have you just sit forward here. He's got an excellent one. Let's have you turn around to the camera here. He's just got an excellent one here too. So we can look at yours too. Now visualize that. Can you see the difference there? Sure. You see that right there? And that. right here, as opposed to, see, the bottom is just buried and you know, down in the tissue there, and this one's just sticking right out. Now, there could be problems in this area that can cause that, you know, that'll cause rotation in the ribs and just hold it out, too. But I think you have to kind of go, you know, you can't instrumentate a scapula and anything like that. So you have to go with the symptoms that they have. You know, if this fellow was having a real sharp pain in this area, and we couldn't find any nerve pressure here at all, you know, it's a good chance that might be the scapula there. One way to watch it in motion is go ahead and just have him lift both arms up real slow, just like that. Just go ahead and start him up there. And just watch him come up there. And see how they move and back down again. Not right behind, it's hard to see there. Okay, now do the same thing, only keep your, let's see, bring them in like this, and more like about like this. And then just bring the elbows out like that, okay? Yeah, it's much more prominent, but it seems to be moving real good. It seems to go up and down, and I think you'll get to a certain point. What happens? You get to a certain point, and it just seems to stick, and it won't come up any farther. That's a good clue that there's some kind of a problem there with the scapula. Just because it sticks out, I wouldn't go adjusting the scapula. Because it sticks out there, like I say, it can be different things. It could be a problem with the clavicle. The clavicle is what holds the darn scapula on. It could be a problem with the clavicle that's causing it. So don't go adjusting that just from that, what you're finding there. Let's see what else he's got here. Well, we got him sitting here, huh? Yeah, that was obvious there. Yeah. Yes, you should flatten out, though. When you're sitting down, you should flatten out in the lumbar. So we expect that. But no, as far as visualizing, what's that?
Flat standing too.
It's flat standing. Okay, there you go. Yeah, it seems to be high on this side a little bit. Seems to have a little bit of dish right here, and it starts. But he's dished here too. He's dished right here too, so I'd question whether there'd be a real problem right there, or whether he's got something down here. How about visualizing their posture? That's something we didn't talk about. That's getting a little more advanced. How about the patient that sits here like this? What kind of problem we got there? Lumbar?
No, thoracic.
That's right, low thoracic problem. Lumbar problem, that'll cause a lumbar problem to hurt. Low thoracic. They bend forward. It makes it feel better. Seems like they're getting away from the pain. Let's see, how about, here's the most common one. Let's say you just round your shoulders off. He can't even do it. He's got such good posture. That's very good, just like that. But anyway, just slump it right on over. In other words, just to bend it right on over like this. You see that a lot. Could have a couple different things. How about if he's hyperkyphotic here? What do you think of? Now, most of the time, a problem in this area will cause it to be dished or hypokyphotic. What can cause it to be hyperkyphotic? How about an alien problem?
Could be PI, ES, could be a base posterior.
Right. Anything that would cause the lumbars to have more curve. How about an AS occiput?
Right.
Okay. Many different things like that. So your posture, you can take a look at the posture too. People will tell you, my back hurts. I know my posture's bad, doc. I've had bad posture for years. Well, don't let them get away with telling you that. You say, look, most of the time we find that the problem, that the posture doesn't cause the problem, but the problem causes the posture. And that makes more sense to them. That makes more sense because that's the way it is. You don't just develop poor posture. You don't stand upright because the problem hurts back there. You'll see him try to get away from a problem. How about mentality posture? I had a guy come in today. Oh my God, was he bent? He was bent. I say he was bent more than that. He was bent. He had the shoulders too. He was like this. He's like that. And he's like that standing up. He's just like that. And, what have we got? Well, we probably got something down low on him. And he sat down and it stayed that way. He sat down and stayed that way, so definitely something going on, you know. But down low, you start thinking about, oh gosh. I know what we didn't talk about too.
I have an old man, 80 years old. He can straighten up with no pain. Okay, but he's always in this position. He can't walk more than 100 feet when he's in pain. Okay. And he's like this. He's been a postural all his life. Okay. And his sacrum sets back, base posterior. I've set that. I started with the second lumbar, and I am getting nowhere fast with it yet.
Nowhere fast, huh? See, second lumbar.
That's what he recommended.
Is that what he recommended for?
Because he can stand up, okay, but with no pain, okay. But if he walks, his legs hurt, and and he gets the pain up. Okay, I did a full lab on him. He doesn't have, nothing to indicate cancer. Hemoglobin hematocrit good. Bone profile is good. Right now I'm setting the base posterior. And
that sounds to me like it'd be more of a culprit, because that would, that's the way you'd want to bend in a BP.
Right.
You can bend forward, but you can't straighten up.
He can extend. Okay, and now he's got fairly good motion in here, but see, his back is real. Real. He's got a reverse curve.
Right.
And he cannot flex forward. To save his life. And
you're fighting with years of compensation. That's what you're doing, aren't you?
And I've been working with the guy for 2 months, and he's seen no change. Okay, of course he goes back to his job.
Yeah, attack.
And so I don't know if I can really do anything for him.
Well, once you got that much, something's been there that long, you just got to make up your mind. That Gonstead, he'd have him up there 3 weeks, and he'd see him 40, 50 times in 3 weeks. How many times you seen this guy?
20.
20 times in how long?
He started in maybe 2.5 months.
See, okay, now compare the ratio, the amount of care he's had with you, now, and he's probably a real extreme of something that's been there a long time. So you take something that's less than him.
Case management notes they talk about with old people who don't want to go so many visits, and now that to me with him doesn't make sense. I don't know. That's a question I have about old people. How much can you go with them?
That is a good question. How often can you go with young people?
Yeah.
You have to take each one's different. If they can come back an hour later, if you set that nucleus and they come back an hour later, the nucleus is back there again, you set it again. An hour later, set it again. If after a while it doesn't improve and it stays bad, then maybe you've got something else holding it or keeping it from staying good. But I say you got to do.
The way it looks to you is that base posterior causing that?
That would be, I've never seen it. I don't know the way you describe it. I would think more of a BP, because you can't extend with a BP. You have more of a tendency to flex, and if he's in a flex position, but then again, geez, you just have to look at everything and decide. He could have a real bad.
If you do extension on him, okay, he'll extend up to about the third lumbar, okay, and then after that it's. So, but I set that second about 10 times.
You say he has pain in both legs?
He gets pain in, that's, I think, because of a posture.
Posture?
Because, he can't, his spine is so whacked out that when he stands up straight, that puts so much strain on his pelvis that causes pain in the legs.
It could be too, well, when you think of bilateral pain, bilateral leg pain, I always think of BP, right? I think of BP, or a real inferior fifth, and if you've got BPs, obviously you don't have that, or possibly an alien problem. You know, you got some type of, Gonstead said, anything that's bilateral, start thinking parasympathetic. Because sympathetic is usually unilateral. Now, there's exceptions, you know, to that, and there's, like the BP is sympathetic, but it could be up top. You could have a cord pressure on him. It may cause him to have that posture too. And anytime you have something bilateral, I wouldn't rule out parasympathetic either. You know, you might have an ilium or maybe a cord pressure too. Again, there again, you guys got to check everything on somebody that old that's had it for. You know what? You probably say, you probably look at it and you probably say you're doing exactly the right thing because you probably are. You just expect, you know.
I just don't know if I can keep them, you know, because he's getting a little distressed.
Well, that's not the point, though. You know, your job isn't to keep them. Your job is just to do your best and get them better. Yeah, my God, you get somebody that's 90 years old and had something for 80 of those years, and you mean they say, look at you and say, you mean I got to come back again? You know, like he's going to take more than once to fix me up. So.
Well, that's the problem I'm facing with him. Is just that man. You know, he's old. He's used to pills.
Yeah. Look, you just send him to Lourdes. That's where they perform miracles. You don't do miracles. It takes hard work to get him better, you know. It takes hard work and time. You know, Lourdes or Billy Graham or somebody, the only person that does it one time. You know. What kind of questions did we have on it? So what were we talking about there? We did a little bit on his spine. Let's just bend him a little bit. Just take a look here. Oh golly. Oh golly. Look right, and then this is, now remember we said this is dish, so I would start thinking about this area and this area here. I'd even be real careful not to do a whole lot in here because this is all dish and you're kind of in a compensated area, I think. But just take a look at this when we bend him. I mean, he comes up just like that. He doesn't even curve good that way. But you see how it breaks there now. Now that doesn't determine whether it's this one on the right or that one on the left, but you can just see that there's definitely a break, and everything's just straight. From here, he doesn't bend at all down there. In fact, this goes this way. If you look at it, watch my finger there. Oh, now he's cheating on me. You see that? Now that bent a little bit to the left. They're coming this way. See it?
far as lines of driver are concerned, with the spinous process or spinous listing, it would be feet away through the disc plane line and slide left to right or right to left. With a mammillary contact, the line of drive is feet away through the disc plane line. There's no right to left or left to right. Spinous feet away through disc, slide left to right or right to left, and mammillary feet away through the disc plane line. Now when we get in that lower lumbar region, fifth lumbar, sixth lumbar, fourth, whatever the last one is, many times you'll notice that they look very inferior on the lateral view basin. Now this disc line is appearing at an S to Y dimension when you set up on the patient. If the vertebra is very inferior, you may not be able to get that setting having your elbow in that S to Y dimension going through the disc plane line. In a case like that, you have to treat it like a sixth cervical, and that you'll have to use some roll with the arm and shoulder to lift that vertebra up and onto that disc space. Just as the sixth cervical disc in the sitting position is in an S to Y dimension, we don't thrust S to Y, we have to come up and lift it and lay it onto the sixth cervical disc. So if that last lumbar is not moving for you on this table or any other table, that may be the reason. Otherwise, it's strictly through the disc plane line. We always get to that on that last lumbar, even if we have to do a bit of an arch or shoulder roll or scoop or whatever you call it. We always make it work for me. Now, if you go any further, I'm going to need somebody up here who doesn't mind being set up on for a long time. Any tissue paper? Yeah. I'm going to have you face me this way with your head on this side for now. Anybody have questions about positioning of the patient? Everybody's gone through that pretty well, I think. As I mentioned just before, it's nice to have that lower leg foot off the edge of the table, so when we do roll them in position, we don't twist this knee that's touching the table or the ankle, etc. It tense up the low back and the pelvis. The shoulder that's contacting the table is brought down and forward just a little bit toward the doctor, so we start out with the contact on their shoulder right behind the point of the ear. We start on the top here, and we roll them into position. It's on the front of the shoulder. Their balance will be off. They feel like they're rolling off the table and be very uncomfortable with their shoulder. Start right back to the table. With the arm, take the upper arm, place the forearm over the hand of the lower arm. They're taking care of each other. They're not flopping around way back here or way down here. That's where the balance is. With the arm portion of the upper arm here, we run it right along the rib cage, we will avoid a couple of things. Having it way back like that gets us in the habit of sticking our thumb in the axle, which we don't care to see. If we have it too far forward, then we get our hand on top of the shoulder like this. That's irritating the shoulder region. When we roll the patient over into position, they'll feel like they're rolling off once again because of the balance mechanism being thrown forward off the table with the weight of the arm. So just run that arm right down along the rib cage. That'll take care of it. Head laying flat on its side on the pillow. Chin up just a little bit to relax the posterior cervical musculature. Hyperextension is no good. Flexion is no good because flexion tightens the muscles. It affects all the way around the lower back. So raise the chin just a little bit to relax the head and neck. That's about it for positioning. On some people, they're very, very flexible. You may have to tuck that lower hip underneath so the upper hip is slanting backwards toward the wall in order to get your balance to start out with. Otherwise, if you have the patient where the hips are pretty well vertical to the table as a starting point, like on this doctor, you'd be in good shape.
Setup for pull exactly the same?
The body positioning for the pull, the fingertip pull, is the same. The patient's body will vary if it's in the middle or toward the edge of the table, depending on the setup. Now, as far as the arms, legs, etc., everything is the same. What you see here is what we will use on every patient for every particular pelvic table adjustment, whether it's the lumbars or the pelvis. It just will vary according to the position on the table, the entire body. When we get all set up, when we look at the patient, we want to make sure that they're running in a fairly straight line, as opposed to having their head and shoulders on that corner and their legs and feet down here, or vice versa. You will find if they're at an angle, they will bind up in that lower back or pelvis. It'll be very hard to move it. So get them in a nice straight line. As general rule now, guidelines, as far as the pisiform push, the larger the patient, that is both in size and weight, you'll have more control leading them toward the center of the table. Because when you roll them in a position, of course the table is going to bear some of that weight. You're not trying to balance yourself or maintain balance. So use the table for the bigger person. You can roll them over flatter, get more power, 20 feet away, and the table absorbs that weight. So the bigger the size, the height, weight, etc. structure, this setup is about in the middle of the table. The smaller the patient and the more flexible, bring them closer to the edge because you can control them easier with their size. Plus the flexibility factor is going to require that you don't roll them over quite as flat without losing that lumbar in the slack. So the size of the patient helps decide where to put them in the pisiform push. Going through the steps now of the setup, whether or not you do it exactly in this order isn't that critical. We present it this way because it helps the doctor to feel the different points of contact and the different points of tension and relaxation to allow him or her to set up and have the vertebra ready for setting on any particular patient. The first thing we will do is position their flexed leg between our knees. We use this to bring the leg forward and backward to determine tension and slack in the lumbar spine. And so what we'll do is palpate the spinous of the vertebra in question, and we'll draw the patient's leg towards the patient's chin or head. And as we do that, that makes the lumbar spine lose some of its arch, in a sense, take out some of that lordotic slack. What we're feeling for in this particular part of the setup is the spinous process, or mammillary, protrude or come back to our fingertip contact, right here. As it does that, as we bring that leg forward, we start stabilizing the pelvis, then the fifth lumbar, the fourth lumbar, the third, etc., until we get to the one that we want to move. The whole purpose in the pisiform push is to stabilize the foundation and whatever is underneath the vertebra we're trying to move. So if I'm trying to adjust the fourth lumbar here, and I palpate that vertebra, as I bring that knee forward, and I feel that fourth lumbar spine start to come back to my fingertip or my contact point, I know that the disc space is lined up underneath that vertebra, and I know that the remaining material inferior to that is in a stabilized position. What's above it doesn't matter. So that's the purpose of the leg position here. Now you'll get a flexible case once in a while that drawing that leg up doesn't take it all out of there, or if you draw the leg up on some patients, it starts to bother them in the buttock or in the leg or the knee, etc. Instead of drawing that leg up and holding it tight to where it may be uncomfortable, take your hands, one on the crest of the ilium, the other on the buttocks, and just tilt the pelvis to reduce some of that lumbar slack. Follow me? All we're doing is just tilting the entire pelvis. That's what you're doing with the knee here, and many times that will not do it comfortably. So simply take the pelvis, reduce some of that lumbar slack. In a sense, you are making it military, although we're not trying to make it kyphotic to make the adjustment, obviously. But we are reducing slack that way. And this is a much better way to reduce slack in the lumbar spine than extending the shoulder posterior. That takes slack out, but it also causes a lot of torsion in the lumbars and low thoracic. So we'd rather see it done reducing it down here with the leg and with the pelvis. Once you've positioned that leg where you want it, you've got that vertebra in a stabilized position as far as the knee is concerned. Have your contact, then we'll roll the patient straight over to the doctor. Roll them over so their shoulders are about straight up and down to the table. That usually gets them over far enough for the push work in order to get enough feet away and control for the lumbar adjustment. Once again, we position this leg first, and we bring them over to us. Have our contact, and the shoulders are about straight up and down. We couldn't take them over quite that far on this one. Now, when we come in and stabilize, we'll stabilize with the anterior portion of our thigh region against the posterior lateral aspect of their thigh. And it is much more comfortable for the patient if you wait with that stabilization until you bring them over to you. Then come in there and stabilize. You've got a pin right there in the table, just like that. And you've got to also keep a nice arch in your low back so you're standing up fairly straight, still getting your feet away and enough adjustment to the disc plane line as opposed to bending way over like this. This is hard on your low back all day long, so we like to see you stay up a little bit straighter if possible. We like to see you avoid coming up to stabilize like this and coming down. This invites rotation to the lumbars. It's very uncomfortable for someone who may have an arthritic hip region. It may bother the epicabulum. If there's an eXilium on the upside, it can also strain or irritate that. So it's much more comfortable to the patient and better for control to bring them over and then come in and stabilize. Both of the doctor's feet are planted on the floor. And if you do this one, starting up here, coming up and down, it invites leaving that lower foot off the floor. So when you adjust, you just roll everything off the table. It's not with the push of your feet. Wonderful, huh? I'm making you that. All right, so we've got them over this far. We've stabilized. The last part of the setup is shoulder extension. We don't put any pressure on this part of this setup until we've got them rolled into position. Because if we held pressure before we roll them over, automatically we're tightening up the low thoracic. So let this, you can contact it. Just let it come along to the right here, get positioned down here. Then extend it superior as far as possible first. As the last resort, we take it posterior. When you take it superior, stretch it out as far as it goes, take it back. This won't tolerate it. We have to loosen up just a little bit so we leave a little bit of comfort in there for the patient's soft tissue. So the right point for setting is having the vertebra close to the tension point, but not bound up at that tension point to where you have all the slack out of there and already straining the soft tissue. So the purpose of the leg position, the hip position, bringing them over and extending the shoulder up and maybe back is to get close to the tension point without getting it so tight that you've got it bound up. If you have almost all the slack out, you thrust, that little comfort zone will be used up very quickly in the thrust, and you won't waste the rest of your thrust time, but you won't have it so tense that when you do try to adjust, it already hurts just on contact. Now you get them to move if you take everything to tension and thrust, but it will not be a comfortable adjustment. You can still get it to move nicely, make it comfortable, leaving that little bit of relaxation in there. Together, contact, you roll them over, I'm going to stabilize, I'm pinning them right to the table, right there. Stretch them out there, etc. Check your line of drive, and we'll thrust. Now you can thrust several ways, depending on the strength of the doctor, depending on the size of the patient, the resistance in the patient, etc. Many doctors can make the adjustment simply by extension of the elbow and thrusting with the shoulder and arm straight into the spine. Other folks need that plus some shoulder drop. Other folks need that plus some body drop. And I'm sure in some cases we all need everything to get it to move. So that you'll have to determine yourself as to how much you need to make the adjustment. Now, we'll start out trying to thrust it simply with our arm. When we get the patient in position, we're ready to give the adjustment. Make sure you concentrate on thrusting straight into the spine. Don't worry about right to left or left to right, etc., because you're getting plenty of that with the position of your forearm when you set up. Think about thrusting directly feet away through the disc plane line, right into the spine, so you don't waste your thrust into something else. I think one of the major problems with people's low back work, when they say they can't get it, and you get these guys that are 6'10" and 250, they say they can't adjust the low back, you know. Here's some little wimp comes in and can do it like nothing. It's because they're losing their thrust someplace beside into the spine. And invariably, they get bent down too low. When they thrust, they drop like this, and the thrust goes right off the elbow. So if you're dropping like this, and that's what's happening, you're wasting everything right into midair. Think only about thrusting straight into the spine when you've got it all set up. Whether that takes the arm and shoulder, the arm and the body. It makes no difference. When we use body drop on this adjustment, it's done by flexing the knees and dropping our body and our shoulder directly into the leg, down into the table in this direction. So the idea is to stabilize this as we drop like that, stabilize, and as we thrust here, the momentum in the drop helps us to get a little bit more power into it. So when we drop, we don't try and roll the patient off the table. If you do a setup like this and roll them down and drop, you will roll them off the table. And again, where's your thrust? Think about dropping straight in with your body, straight in here at this angle. And that'll help you, it'll give you more power and also give you a little bit of resistive force on the bottom. So as you thrust here, this is stable or maybe brought up just a little bit to where the two meet together. That's the proper way to use body drop. Any questions so far? Okay. If it were a flexible patient, the thing that we would do different, as I mentioned, was to bring the patient a little closer to the edge of the table because of their size and flexibility. The pelvis, the leg positioning, etc. is the same. Here, the more we roll those flexible people over, the easier it is for that lumbar spine to just sink right back into what usually is a hyperlordosis. And so we've created slack, we jam the facets, and we can thrust all day and nothing moves. For those, the leg has to go a little higher, tilt the pelvis or both, bring them over, just so you break vertical point to the table. Now on this one, you will have to bend down and get that line of drive, but once you have them set up and a slack out of there, you should be able to thrust with your arm and chest region and get that to move. It should not be that hard. It's when we roll them over too flat and we lose it that it takes all the power to move nothing. So when they're set up properly, we don't roll them over quite as far, therefore we must bend down and leave a little bit more and come straight into it with the feet away. Feet away into the disc spine line. The spine is so right to left and left to right in your forearm set. That's about it for the lumbar push with the bicep point.
So if we make a comment on the forearms, but not to lose the thrust, not to control the position of the forearm.
It's the concentration when you go to thrust of having the thrust arm relaxed for one thing, or pretty close to that, and thinking about thrusting straight into the spine, and in doing that you are extending or straightening out the elbow. Many people when they thrust and use their body drop, they let it go down like this. And so they flex the elbow rather than extend it, and all the thrust goes right out the end of the electron on here instead of to the bicep.
Should we start off with that forearm more parallel to the disc?
I'm not sure what you mean by parallel. I mean, as far as this was concerned?
Yeah, we start off with just extend from the elbow.
Once you have the patient position, let's say we're right here for a fourth lumbar. All right? I've got through the disc plane line in this dimension here. I've got enough right to left in this dimension, the way my forearm is pointed towards me down here. Right? So right now it's a matter of thrusting feet away. I thrust straight in this way as opposed to down this way or this way. Is that clear?
When you said the right to left on the floor, you said it's just not that right.
Right, just in this setup position here, and being on the right side of the spinous, hooking a little bit there, plus on top a little bit farther flex here, giving you enough to get the rotation out of there. Now, if there's an extreme amount of rotation, you may want to hold that one, because the pull with the fingertip will give you a little bit more advantage for that rotation. Otherwise, on this biceps adjustment, I wouldn't worry about anything except thrusting straight in, of course torquing when it's necessary, once you've got your forearm in position. Otherwise, you end up wasting your thrust someplace else. Anybody else? Well, then why don't we talk about the full setup too, and then we can go ahead and work on those for a little bit. You want to get up here? Okay. With the full move, it's actually a push with the fingertip contact. We do not want to come across with the idea that we're twisting or rotating the spine in this adjustment, and that we're not trying to totally take out rotation, although just in the mechanics of the setup, rotation is reduced more so with this move than it is with the bicycle push. And it's easier with the bicycle push to reduce posteriority than it is with the fingertip push. So we do want to get across the point that in this particular adjustment, we are thrusting feet away into the spine, not rotating or twisting in the adjustment. So when we use the fingertip contact, we use one finger supported by one or maybe two, depending on the comfort of the doctor. The side of spinous rotation is always down to the table, no matter what the listing is, or whether we're having the spinous or the mammillary process. So right side down, it's all right listings, left side down, all left listings, whether it's PL or PLS or PLI, mammillary, etc. When the spinous is the contact point, that finger is hooking right underneath the spinous process on the inferior border, and the fingertip is also standing up on top of it, much like the bicycle contact here. And you can hold your hand in one or two manners after that. Either stand your fingers up and the thumb on the paravertebral musculature, making what we call a rat hole like we do in the cervical chair. Or you can leave the arm close to your body and flatten the hand out like this. Some people find this more comfortable. Gonstead did it like this. Stood his fingers up, stuck his elbow out here a little bit. So when he gave the adjustment, he thrust into the spine with his shoulder and arm and wrist, etc. You can also do it having your arm flat, pulling in this way, using your biceps and pecs a little bit more in the thrust. Either way will work. Those two ways. If it's a mammillary contact, once again, the superior part of the spine is just lateral. Here, the fingertip fits in nice because of the smaller contact or the smaller segmental contact point. And once again, you just stand the fingers up and put them flat. The big difference in getting this adjustment to work properly, preventing it from being a lumbar roll versus a Gonstead fingertip push, called the pull move, is the leg kick. The way the control is maintained on the pelvis and the lower back. The kick is done by thrusting down into the table. The end of the table factor is what saves us from making a complete rotary twisting of the low back. If we just thrust straight down to the floor, we simply twist the entire spine, low thoracic region. As we kick down into the table, however you want to do that, I think the easiest way is to thrust right through the front of your tibia. Once you position that leg thrust straight down into the table, what you're doing is creating a counter force that shifts the pelvis and the vertebra underneath the one you're adjusting up a little bit, even though the entire body may be coming towards you. At that split second when you thrust with the leg and the fingers, the mechanics at that joint are making the lower portion meet the upper portion. That's how he explained it. And so we are creating a push move here, stabilizing with the kick instead of rotating everything in the same direction. I'll need you back again. Yeah, you can switch. Now remember, the body positioning is exactly the same. We will have to bring the patient close enough to the edge of the table here to leave room between the inside of the thigh on the leg that is flexed, being the upper one here, the inside of that thigh, and the edge of the table. We certainly don't want them back too far that when we thrust, we shove that femur right into the edge of the table. So irregardless of the size of the patient, they will have to be a little closer to the edge. Now, the bigger patient still will be farther back than the smaller one because the size of the thighs and the hips is going to raise this leg up higher, so it will have more room farther back. But the point being to make sure that no matter what the size of the patient is, if you have them close enough to leave room to thrust. And you can check that out by bringing that pelvis just past vertical to the table, that is toward you, as opposed to back here. Just past vertical, make sure there's room in there for the leg kick. Now, let's say we're doing a PR pull here. Fingertip, I hook underneath the spinous process, I can either stand my fingers up like this, or I can leave the arm flat and tuck it in close to make the adjustment. We do the same thing with the leg as we did before. We have to determine where the slack and tension is in the low back. Once we have that, we must maintain that leg in this position, because if we let it slide back down, we've lost the idea. So make sure it stays there. It may require that you hold it there, or drag your leg up behind their leg so you hold it in the position. Now, once we have our leg in position, usually that will be having their knee right in front of our ankle on your average sized person or patient. Someone who's taller, that is the doctor, won't be able to have his leg up that far in order to get that contact with the knee is flexed in front of the ankle. That doesn't matter. Don't get your knee any higher than the bottom of the buttocks. It will serve you no purpose to be up this high. So get it down just below that little field tissue. If you have it lower than that, it's easy to get pressure on the acid happen once again, and once again, if there's a knee ischium perhaps on the upside, you can open that up and cause it to be more painful. So right about there, so the top of your knee is just underneath the gluteal tissue. And in most cases, that will be having the patient's knee that is flexed contacting the front of the doctor's ankle. When I thrust in this kick move, what I want to see happen is this lower portion come back a little bit. We won't do it here. Just a second right there. So we counter forcing like that. See? That's the idea. There. Watch this again. Here's the proper kick. If it does that, brings this up a little bit, you know you're getting that counter force of stabilization just like you are when you thrust in here with your thigh. And when we thrust with our fingers at the same time, the two parts have to meet together. So the thrust with the arm and the leg is simultaneous. That's the only way this will work properly. And the more control you get with this, and the more you can make the adjustment with your thrust hand versus your kick, the better your adjustment will be. In the beginning, if you just get the two doing the same thing, doing this kick and the thrust at the same time, the kick and holding pressure here will make it move. We'll get some movement on it. The concentration on P to A and thrusting into the spine makes a better adjustment as you get better and more control with it. This particular move is harder to watch the pressure on the shoulder region without involving the low thoracic. So once again in our setup, when we get them in the position, we'll roll that patient just past vertical to the table. That's how far you should bring them over. That'll give you enough room to kick. And then we'll stretch him out. Superior, we take him back. There he's tight already, and you feel that with the resistance here and with the muscles down where your fingertip is making the contact for the thrust. At this point in time, the best thing to do to coordinate this setup is to get the 3 points moving together. Here you develop a sense of feel and coordination among the 3 points of contact. So when we do thrust, we can maintain this relationship during the actual adjustment. Because if you thrust and have all the slack out with a little comfort right now, and you thrust and hold that hand in position, and this rolls towards you a little bit, you still create a tension in the low thoracic. So you must let that shoulder come along invariably. So the proper adjustment when we thrust here and here is allowing that shoulder to ride along a little bit so we don't create an adverse strain in the low thoracic. In order to help you do that, your balance should be directed over the segment or below it. And you do that by making sure the leg that you're standing on and balancing your weight on is about in front of the patient's abdominal area. Some doctors get it way down here below the belt or touching the patient's thigh, then they have to shift their weight this way in order to stand up. If you get your leg that's touching the floor in front of their stomach, rest it into the table if you like for your own balance, then you can turn your body slightly so you're facing the segment straight away and concentrate your weight right here or below it as opposed to up here. You will avoid too much pressure there. So once again, it looks like this. Thrust down to the table, put the fingers at the same time, let the shoulders come along just like that. Now some of these You can thrust it from a static position. That means once you break that vertical point to the table, you can thrust right there without involving some motion with the body. There's nothing wrong with involving motion and coordinating the three parts and making the adjustment during one of those movements when you felt the slack was out, the patient was relaxed, and you were ready to thrust. As long as you let that shoulder come along, during the actual adjustment, kick properly, you'll still get the same adjustment when the two pieces together. With the feet away adjustment. So concentrate on thrusting into the spine, utilizing all this stuff straight in, or if it's here, straight in like that, as opposed to twisting it off the table. Good? Anybody? Questions?
You were talking about rocking.
Yeah.
That's got both ones in the
If you watch any of the folks adjust, Alex does, whomever, and Gonstead, many times you would see them do this. They'll give a little test kick here, kind of get a feel of things, stretch it out, kick a little bit here. What we're doing is just making sure the slack is out, but we don't have it bound up. And we feel them relax, and when we're ready, we let them have it right there. And that's the coordinated movement I'm talking about. Not that you prime everything by pumping it a few times, no. The old Harley Davidson they talk about. We're not trying to do that really. It's just to help you. And if you don't need that, fine. You can do it right here, fine. But you can do it this way, get a coordinated feel of the 3.2 contact. So when we thrust here, maintain that relationship. Maintain it, let your shoulder come along a little bit. Don't go pressure on it. Anyone else? Well, let's go ahead and work a little bit. Okay. With the bicycle. The routine position in the average case is having front of your thigh contacting the posterior lateral aspect of the patient's thigh. Now you will find that clinically on a smaller person, a more flexible patient, you'll probably have to get a little bit more posterior on their thigh to hold that leg and buttocks in the position to maintain the close detention point, or that is getting the slack to stay out of it. Because in most of those, if you don't stay a little bit more in the posterior aspect, that leg will tend to slide back on you, and then the lumbar spine dips back in to that hyperlordosis or hyperflexibility, and thus that's just jammed. On the heavier patients, both in size and weight or both, you'll probably find it more advantageous to stay a little bit more toward the lateral aspect. As you drop down into the table, you're getting that big thigh and hip to come down and carry some of that counter force with you a little more effectively, being on the lateral aspect. So you as a doctor will have to determine where you feel most comfortable on that thigh. The posterior lateral combination of both is the routine position, but it may vary a little bit more posterior or a little more lateral according to the size of the patient and what's more comfortable for you. Other thing to watch is to make sure your pressure, when you come in to stabilize and pin that patient into the table, whether you turn into them this way or come on the side and just go straight into them this way, make sure the pressure comes in the upper part of your thigh on this portion of theirs. Don't get the pressure down around their knee, and don't get your thigh against their tibia with pressure. It's going to contact that. But if you come in with weight and pressure against their tibia, it will hurt there, plus it usually will push into the edge of the table, which will also be uncomfortable. Make sure you concentrate your body pressure and weight on their leg up in here and the buttocks. Yeah. Could you go to the basic stance approaching the patient? The basic stance approaching the patient? Right. For either one, the first thing we'll do is pretty much go straight away to the pelvis, having their leg flexed so it's between ours. That allows us to do this, bring their leg, say the head's here, forward toward the head or down toward the feet. As the leg is brought down toward the feet, it introduces more slack into the lumbar spine, hyperlordosis. As the leg is drawn toward the patient's head, those vertebrae, those disc spaces start to even out in a sense, if you will, where you stabilize the vertebra as you go from the bottom up toward the top. So as we draw that leg up, we are stabilizing. That's the purpose of doing it. After we've got that leg in a position where we feel that spinous or mammillary process come back to our contact point, whether we're just palpating with the superior arm or having our pliceform or fingertip in position, it doesn't matter. When we feel that, the leg is flexed toward the head or the feet, no. We must maintain that particular position for the rest of the setup. That means when we roll them over to us, we bring that straight over. We don't let that leg slide down. On that flexible one, that leg is going to slide down easier than on someone who's just your average patient who stays right where you put them. So that's why I mentioned a minute or so ago, when they're flexible, you may have to turn your body and come a little bit more behind to hold that right there, see? And then go down and make your adjustment. On the big one, just roll them over to you and come more on the side of the thigh straight down here. Alright, is that clear? Everybody else got that? Not confusing. No other questions about this one? This table here, I think everyone knows how to use the chair as far as the positioning, etc., the strap, right? About that.
You better go there.
Okay. You know that the chair has varying heights that you can accommodate the height of your patient. So the notches will allow you to lower the head support of feet depending on the size of your patient. The first notch will usually be the proper position for almost all your patients unless you get someone who's very tall. Patient positioning here, you want them sitting up straight, you want their buttocks right against the back of the supporting piece here rather than slouching down. So sit them up straight so the shoulders, etc., stay back into the chair. If they slouch, you will be underneath the vertebra or resting from behind. If they lean forward on you, you've already lost the whole works in slack. Again, hypolordosis. Even if you have a military kyphotic neck and they're leaning forward, you created slack, just like letting that lumbar spine sink back in your rotation over. So make sure they stay back into the chair. Thing to help you is the strap. And so if you see this strap or on the chairs or have one yourself, that's one of the reasons for using it, is to hold the patient back into the chair so we don't have to go through pulling them back all the time to make sure they don't go forward and slack. So that holds them in the position. As far as their legs are concerned, flex with the knee so they're past vertical to the floor. You do not want to see the legs to where the feet are underneath the table. When they're in this position, they have strength to resist you by pushing against the floor. So let the feet go past vertical to the floor. If you like, they can rest on the heels. Dr. Gonstead talked about that in the last year or two of his practice, having them rest on the heels for more relaxation. The only danger there is in the long behind a leather chair, it's easier for them to slide down on. So it's not necessary on the heels. If you like that, that's fine. Just make sure they don't sink away from it. Simply flat on the floor, past vertical is sufficient. The hands resting on the lap, palms up or down. I don't think that really matters as long as you don't try and push or resist you. Definitely not holding on to these little handles. I think these nails are just moving the chair around, not for any other reason. So, resting on the lap, definitely not crossed like this. The strap usage, it goes underneath the axilla of the stabilization, or excuse me, the thrust side, and across the top of the shoulder of the stabilization side. So if I'm adjusting from the right, I'm going across the left shoulder underneath the right arm, and vice versa. In addition to holding the patient back into the chair, the strap also helps if your thrust is slow. If you're in the upper thoracics, you're stabilizing from the front at that particular level, since you can't really get your arm out there that well in the thoracics and the rib cage here. And also in lateral flexion, some patients have a tendency to draw the shoulder up on their stabilization side. The strap can hold that down in position. So there are advantages to using it. They don't use it at the clinic. Gonstead used it in the last few years of practice, but he did not use it all the time. So it's not necessary if you have good stability and control. But it is very beneficial starting out or if you don't have the stability and control.
But is that beneficial on a woman patient?
I would say it's more for the woman doctor, the woman patient. I'd say it's more beneficial for the woman patient because they're usually going to be smaller, lighter, more flexible. They'll tend to lean away as soon as you make contact. They'll start moving away from you. The strap would hold them in a position. and being flexible, and maybe this number two, and that will also help hold the position. So I think it's beneficial. I would recommend if you're going to use it from day one. If you've been adjusting somebody and then you want to fit this, and you can't get it, you start strapping them in, and there goes the one. All right. We're going to start with the atlas. Now we'll do the atlas adjustment in the sitting position if we have AS listings. S, as you know, being the position of the anterior tubercle on the lateral film. The AI atlas adjustment will not work in the sitting position because we can't arrive at the proper torque. When we thrust in the atlas adjustment, going level, palm is turning naturally palm up, and so whether it's from the right or the left, the torque activity there reduces that anterior tubercle position from being superior, dropping it down to level. That's the purpose of the torque in the sitting position. The AI ones, if they're dropped down, we can't turn our hand in such a way as to raise that tubercle up without getting our hand pushing into the posterior part of the cervical musculature. So AS listings in the sitting position, any atlas adjustment can be done in the alternate position, whether it's AS or AI. But we will try them sitting first. AS listings. Question?
Just a slight verification, man. What one? It's obvious what an AS atlas will do. How, as far as symptoms, can you differentiate an AI? Is there any differentiating symptoms or curvatures that can?
I would say a lot of appearing AIs are due to compensations from a kyphotic neck. They may not really be AIs. I really don't have any other comment about symptomatology because he always felt the majority of the problem with the atlas was laterality, rotation being next. And so whether it's S or I is not going to affect that too much, or the symptoms arising from the capsular swelling, etc., from the lateral wedge. Really have nothing else to say about it there. Anyone else? With the atlas adjustment then, say we're doing them in a sitting position. Our contact will be with the tip of our thumb. Now your thumb may bend a lot like this one, or it may remain straight. You will vary your contact according to what your thumb does. It will not be comfortable for someone who has a very flexible thumb like this to come in contact on the very tip here without causing flexion of the thumb or spraining of the thumb, etc. So if your thumb bends a lot, you're better off to contact a little bit farther, so your thrust is coming through the radius and out the distal end of this phalange, which is not good. If your thumb remains straight, you can go right up and that's fine. In either case, we want to keep the thumb in close to the index finger and the palm of the hand, so we maintain some stability and control there. The hand itself can be cupped a little bit. If you leave it real flat, I think you'll find your contact is too harsh because you'll be carrying too much weight from the thumb itself on the transverse. So let the hand relax a little bit. The wrist should be level. If it's extended, that's all right, but don't let it get flexed like this. If the wrist is flexed, you'll end up wasting your thrust to the distal end of the radius, going out the carpals, just like you would have been out the elbow if you didn't thrust straight into the spine. So the wrist should be at least level. That's all right. Extended strengthens it a little bit more. The forearm itself should be level to the floor because our thrust is going to be level. It's going to be right to left or left to right and level to the floor. We're trying to slide it straight across. You'll be over far enough to the right or to the left for your best advantage if you have your elbow approaching 90 degrees. I know it's 86 and a half or 94, that's okay. But somewhere in the 90-degree range tells you you're not too close in like this or you're not too far out here like this. 90 puts you in a good position to the right or left side of the patient, depending on where you're adjusting. So we're ending up with everything being pretty well level here, and about 90 here. That's the arm, wrist, hand, thumb position right there. So when we thrust, our line of drive is right to left, or left to right, level to the floor, and there has to be enough S to I It's just the right amount, for those of you that had Dr. Miller on there, just the right amount. So you have that head tilt slightly when you thrust. If you don't have just enough of that STY, when the head tilts slightly, you'll end up just pushing the head and neck away with a level thrust. So there is some STY involved in there. It's not all STY. The concentration is level to the floor, right to left, but enough of that STY in the mechanics to let that head just tilt slightly to the thrust side. If it does that, then we have the mechanics to work to allow that to slide across. What we're doing is moving the atlas onto the axis, and what happens, what we feel happens is the capsular ligament on the side of laterality is swollen and expanded, so it wedges that side up from the body of the axis, and then it can slide up toward the adductor on the opposite side, or right there, squeeze it under a little bit because of the inflammation. So our concentration is to take it back, straight across, to close that capsular area, and we need enough STY to make it come down slightly to fit the body of the axis on the opposite side. You can picture that in your mind. So when we thrust, there's just enough of that STY to do that to get the mechanics to work. But the concentration is level to the floor and right to left. That's why the forearm is level to the floor. The upper part of the forearm here. Now this may look like it's hanging down, depending on your arm. But flat right up here will be okay. Wrist level, maybe a little extended, and thrusting straight across this way. Here's the action of the thrust. Straight into the neck, right to left, level to the floor. Torque, this way, palm trains up. Now, the adjustment is done with these muscles, triceps, chest and shoulder. The concentration is on triceps, and we do it short and fast, just like that, right there. So when you see the thrust done, the arm isn't going to be moving like that. If you try and push with the arm, your thrust will be too slow. Once you're in position, you set it. It's just the muscle action, the speed of the contraction that makes the adjustment work effectively. Gives you the speed that you need. And you can add depth. If you go short, you can add more depth by increasing the contraction or pushing a little bit with the arm if that's necessary. But don't worry about trying to make the other transverse vibrating inch stabilization. That was going around for a while too. But all you need to do is set it with enough depth to get the audible sound. And the characteristic audible, as you probably know, is almost two sounds simultaneous. Two notes, as you call them. G notes. That's good. Okay. Come on, wake up here. Two notes, almost, our sounds almost simultaneous. That's the characteristic atlas sound. So if we only get one, we will thrust again at times as well. But invariably, they're at the same time, pretty close.
Bill, how do you agree deal with the